So good afternoon. This is session 9. We have 3 speakers for this session. I will introduce each one. Each student has about 10 minutes to present, and then following their presentations, following all 3 presentations, is when we will have opportunity for question and answer. So our first speaker is Macie Vanek. She's a junior at North Carolina State University. She's pursuing a degree in human biology with a minor in nutrition. She is a member of the University Honors Program, and she is on track to graduate in the spring with a 3.99 GPA. During her time at NC State, she helped found the National Organization for Rare Disorders chapter, where she has served as outreach coordinator and spoke to the North Carolina Rare Disorder Day. After graduation, Macie plans to pursue a career in healthcare field, either in emergency medicine, nutrition education, or lactation counseling. So let's welcome Macie for her presentation.
Hi, everyone. As Dr. Kennedy introduced me, my name is Macie, and in this presentation, I will be unpacking the need for enhanced continuity of care between physicians and nutritionists. To begin, heart disease is the leading cause of death in the United States. In fact, 1 out of every 4 people die from heart disease. This leads me to the question, should the healthcare system be doing everything in its power to help develop a course of treatment and prevention for heart disease? The development of heart disease is multifactorial. This means that diet, genetics, exercise, upbringing, education, and environmental factors all play a role in advancing heart disease. There are known risk factors, which are hypertension, diabetes, cholesterol, and obesity. Diet is a strong player in the development of these risk factors. First, I'm going to discuss 2 diets that research has shown to help prevent heart disease.
Out into that ether.
The first is the Mediterranean diet. Researchers found that the Mediterranean countries had lower rates of heart disease. So they took foods commonly found in their diets and created the Mediterranean diet. This diet is full of plant-based foods like legumes, nuts, whole grains, vegetables, and fruit. The main source of fat in these diets is olive oil and fish, which contain a good type of cholesterol that helps remove bad cholesterol from tissues. The other diet that helps prevent heart disease is called the DASH diet. DASH actually stands for Dietary Approaches to Stop Hypertension. As mentioned before, hypertension is a risk factor for heart disease, and this diet was created specifically to help prevent hypertension. This diet also consists of fruits, vegetables, whole grains, low-fat and fat-free dairy products. Fish, chicken, and legumes are also a suggested choice of protein. To prevent heart disease, this diet focuses on low-fat and low-sodium foods. Despite what we know about these 2 diets, they're not actively being implemented as part of treatment and prevention for heart disease. The overall issue is that most physicians are not equipped to give nutrition counseling, and it's much easier for doctors and even the patients to just take medications. This is why it is important for doctors to work with nutritionists in the management of heart disease, because nutritionists are specialized in nutrition education and know the benefits of a healthy diet and are able to help patients reach their dietary goals. I sought to answer 2 questions in my research. The first question is, why should nutritional interventions be used over medications in the treatment of heart disease? First, I found something quite interesting in the study of the DASH diet shows that the diet alone was able to help lower systolic blood pressure, which is the top number of the blood pressure, about 6 to 11 millimeters of mercury, without even changing other lifestyle choices such as exercise, just by the diet alone. This is important because it means that dietary alterations can be just as powerful in the treatment of blood pressure, which is a risk factor for cardiovascular disease, as medications. In fact, the study claims that diet should actually be considered a medication for hypertension. Another study that I looked at who followed the DASH diet for people who followed the DASH diet for 8 to 20 weeks saw an average weight reduction of 13.13 pounds. This is considered a healthy and sustainable amount of weight loss. And as mentioned earlier, obesity is one of the risk factors for heart disease. This means that the DASH diet reduces this risk for heart disease. And medications that are used to manage cardiovascular disease often don't lead to weight loss. Looking at the Mediterranean diet, studies that analyzed them found similar results. In my research, I found that people who abided by the Mediterranean diet had a 9% decreased risk of mortality from cardiovascular disease. Circling back to the question, why should nutritional intervention be used over medications in the treatment of heart disease? I would argue that dietary interventions are more holistic than taking medications. Just by changing your diet, it can decrease many risk factors for heart disease. It can help lower blood pressure, lose weight, and decrease one's overall chance of mortality from heart disease. If you want to reduce these risk factors with medications, you would have to take multiple medications for hypertension, cholesterol, and weight loss. These medications can have a lot of negative side effects, and oftentimes you'll have to take more medications just to combat these side effects. There are no bad side effects from following the DASH diet or the Mediterranean diet. Also, these medications can be very expensive. Eating is something that humans already have to do, so it shouldn't be much of an added cost to switch your diet to something more healthy, especially if it reduces medical visits and medical expenses. Also, this is why it can be helpful for people to work with a nutritionist. Nutritionists can help them apply for programs to help with food affordability. Additionally, they can help give people ideas about foods that are enjoyable, time-conscious, and culturally relevant. Doctors play an important role in helping patients identify risk factors for hypertension. Instead of doctors directing patients immediately to prescription medications, they should direct patients to a nutritionist. The second question I sought to answer is, how can we practically increase continuity of care? Doctors are super busy and nutritionists are super busy, and how are we going to practically increase their communication? I found research that mobile apps can be an effective tool to help increase continuity of care. The idea is that a patient can use an app to track their dietary intake, record their blood pressure and other measurements over time. Then a nutritionist and a physician can have access to the information, write up their clinical notes so that both providers can see, and even notes for patients to be able to see and keep on track. So far, the research has mostly focused on whether the apps help patient manage hypertension and follow dietary restriction. So more research and development needs to be done in this area. Another solution that research has shown to help nutritionists and physicians provide care together is called community-based counseling. In this model, nutritionists provide counseling in a community setting, such as a grocery store. And at the grocery store, they'll provide counseling to patients, and then nutritionists will communicate with doctors to help them manage their prescriptions. Overall, my research, I found that there is little question about the effectiveness of the DASH diet and the Mediterranean diet for heart disease. In order to begin to normalize dietary approaches for the treatment of heart disease, there needs to be enhanced continuity of care between nutritionists and physicians. Some potential areas of further research and development are apps and community-based counseling. Thank you.
Thank you, Macie, for this informative presentation. As I said in the beginning, we'll hold all of our questions to the end. So our next speaker is Grace Weinkopf, who is a senior nursing student at University of North Carolina, Greensboro. She is both a member of the Lloyd International Honors College and is part of the Disciplinary Honors Program with a major in nursing. Grace is pursuing a BSN in nursing, and she plans to work in surgical ICU at Health, Wake Forest Baptist Medical Center following graduation. During spring 2020, Grace studied abroad in Sweden at Linnaeus University, and she is an active member of the Association of Nursing Students at UNCG. So Grace, I will turn the presentation over to you.
All right, let me share my screen real quick. Okay. Hello, for my senior honors project, I conducted my research about preeclampsia prevention, screening, and assessment. I focused on the development and use of an early maternal warning standardized protocol to reduce maternal eclamptic incidence. I know that sounds like a lot of big words, but we're going to break it down during my presentation. For my project, I started with the general question, what can we do as nurses to prevent poor outcomes resulting from preeclampsia? First, let's discuss a little bit about what preeclampsia is, and then we can get more into my specific research for some background. So preeclampsia is a potentially fatal condition that occurs during pregnancy. It's a progressive condition that begins with high blood pressure and other organ dysfunction in the mother that can lead to seizures, otherwise called eclampsia. It can also lead to premature labor, and when not controlled properly, it can be fatal to the mother or child. The exact cause of preeclampsia is not known, but it's hypothesized that it relates to the general vasospasm or clamping down of the vessels that causes abnormalities with the blood flow and other organ function. There's no exact reason that has been identified that causes the vasospasm or exactly how to stop it, but generally the condition resolves after birth occurs. There are theories that it's related to the placenta, but this has not been. For my research topic, I wanted to find a way to notice and assess the signs of preeclampsia earlier so that we could notify a doctor and intervene before the condition progresses too far. Initially, I wanted to develop an early warning score that has the nurses input their assessment findings and consistently monitor blood pressure, and then it would populate a score for how at risk a laboring mother is for developing preeclampsia. But then I found out that these types of scores actually already exist. The ones in play are for a larger umbrella category of many maternal complications that can occur during labor. Once I learned that these systems were already in place, I decided to look and compare them based on how easily they can be implemented into practice, what signs and features will trigger these different alarms, and most importantly, why we need these types of scores and how they will improve outcomes. So this is my PICO question that I based my research on. Basically, the goal of my research is to see how we can reduce bad outcomes associated with preeclampsia. I chose this project because of a very specific experience I had in a clinical. To make a long story short, I came into one of my labor and delivery clinicals for school to find a patient that had seized overnight during the labor process and was now on magnesium sulfate, which is a very high-risk medication. After looking back through her chart with my instructor and a nurse, we saw that there were sustained high blood pressures and other severe features that should have been noted for potential preeclampsia on her assessment, but she was not appropriately medicated to prevent her condition from progressing into seizing or eclampsia, which ultimately it did. Not only was this a safety issue for the patient, but also a family issue because the mom and dad were aware that she was now having to be heavily medicated because of the lack of appropriate care the previous night. The couple times I went into this patient's room to care for her and the baby, the mother was groggy, sleepy, and not fully with it because of this medication she had to be on. This mistake caused this mother to spend the first day of her child's life excessively fatigued and heavily medicated to compensate for the lack of intervention that had occurred the night before. This day has stuck with me since it happened in my first semester 2 years ago when I started nursing school, and is one of the main reasons that I was drawn to research preeclampsia prevention measures and tactics. At the end of the day, preeclampsia is a condition that can be treated with better control and can reduce poor outcomes when it's detected earlier. Now I'm going to give you a little background on preeclampsia and what's involved in the assessment of these severe features, and then I'll explain how the assessment scores work. So preeclampsia is considered a hypertensive disorder of pregnancy. The number one symptom that would alert a nurse or provider to look for other signs of preeclampsia is high blood pressure or hypertension. This assessment is important because it will differentiate between preeclampsia or simply gestational hypertension. Preeclampsia and high blood pressure during pregnancy is the presence of these other severe features, which is what the nurses and providers assess for during pregnancy and more intensely during labor and birth. So these are a list of these symptoms or severe features, as they call them, that are monitored to identify and diagnose preeclampsia. My research project focuses on the idea that if we can identify these features in a pregnant woman with high blood pressure earlier, then we can treat her less invasively and slow the progression of her disease. Through checking reflexes, asking about pain and vision, checking lab values with blood work, and taking a urine sample to assess for protein in the urine. Proteinuria is typically a consistent sign along with high blood pressure that can elevate a diagnosis to preeclampsia. So blood pressure is our most important thing that we look for. Blood pressure is monitored in a pregnant mother throughout their entire pregnancy, starting at their first prenatal visit. This is so important because it's the first sign of preeclampsia and serves as a baseline reading to compare later blood pressure measurements to throughout the pregnancy. When an expecting mother shows signs of hypertension in pregnancy, testing for protein in the urine is the next step at a prenatal visit to monitor if her hypertension diagnosis is elevating to preeclampsia. Without the risk or in-depth assessment for these findings, the mother is at risk for eclampsia or seizing, which is really, really dangerous for both the mother and child during labor and can result in a fetal demise. Preeclampsia also puts the mother at risk for placental abruption during pregnancy or preterm labor, but also hypertension, chronic kidney disorder, heart disease, and other cardiac disorders in the postpartum period. With good screenings and informed assessment, interventions can reduce the number of cases of eclampsia and can delay progression of preeclampsia altogether. Research has shown that although preeclampsia is a risk factor for the possibility of preterm labor, the poor outcomes for both mother and child are preventable with timely and effective care regarding blood pressure and prediction models, which we're going to talk about next. Oh, I skipped a slide. There we go. The California Maternal Quality Care Collaborative, or CMQCC, has developed these toolkits that essentially aim to set a standard of care for a patient who is diagnosed with preeclampsia or is at risk for preeclampsia. This toolkit includes the verification of blood pressure, the treatment of a critical blood pressure reading within 1 hour of confirmation, among other guidelines. The guidelines set forth in this toolkit also align with the recommendations set forth by the American College of Obstetricians and Gynecologists, or ACOG. 24 hospitals of various backgrounds and locations implemented this toolkit to standardize their care for these patients, and 41% of those hospitals met their goal of successfully implementing the toolkit interventions. The conclusions from the hospitals show that the CMQCC preeclampsia toolkit significantly improved maternal outcomes and achieved their goal of reducing severe maternal morbidity. Although the hospital systems did experience challenges when standardizing their care for these patients, they overcame these challenges in the end and improved patient outcomes as a result, showing how standardizing care for these types of patients is shown to improve not only monitoring, but assessment and their outcomes. So while we do have a toolkit that shows improvement in the outcomes, it has to be implemented as a standard of care for it to work. And currently the practice at many different hospitals varies for assessment and monitoring based on what the provider orders. Although the current implementation rate of this standardization is low, high levels of compliance with the standardized treatment can be achieved quickly with easy adoption of the toolkit policies. So next we're going to talk about an early warning score, which was my original idea to develop. For those of you that don't know, this is how an early warning assessment works. This table shown here is the MUT, or the maternal early warning trigger. Essentially, you have a certain number of signs or triggers that are out of range for a normal reading, like blood pressure, heart rate, respiratory rate. And then if they stay that way for 20 minutes, they're categorized as a yellow trigger or a red trigger, prompting the nurse to reassess the patient. This type of system would typically be based on an automatic vital signs monitor, and it would populate in the electronic health record that would then show on the screen and alert the nurse that their patient is a yellow trigger or a red trigger. This system can help you identify an abnormality sooner because of the calculation and alert system done by the computer, which will help nurses and providers observe and intervene when they see an abnormal vital sign, which can be one of the first indicators of a disorder of pregnancy like preeclampsia, sepsis, or hemorrhage. These three systems shown here all base their vital sign criteria off of the ACOG guidelines for diagnostic criteria of preeclampsia, which also lines up with the CMQCC toolkit. I'll tell you a little bit about each warning system and what makes them different. First is the MEOWS, or the Modified Early Obstetric Warning Score, which is designed for 20 weeks gestation until admission into the hospital and is then stopped and then resumed in the postpartum period. It's not designed for active labor. The fact that this score exists really emphasizes the need for early recognition of these alterations in vital signs during pregnancy that can indicate preeclampsia before the mother is even admitted. Next, we have the MUC, which is loosely based on the MEOWS, but was designed to be used while the mother is in active labor. The MUC does not have triggers or pathways like the MEOWS and the MUT do, but instead the MUC warrants an assessment from the provider with any abnormality. The MUC has higher criteria values than the MUT, and the meows, but the trend of values is not included in the score. It's more of a binary assessment. Either the patient needs to be reassessed or does not need to be reassessed. There's no trend shown. And finally, we have the MUT, which is shown on your screen. The MUT looks at trends and has two categories of triggers, the yellow trigger and the red trigger, warranting a response from the provider if you have two yellows or one red. The ability for nurses to identify a trend with the MUT greatly helps with early identification. So the results of my research. Ultimately, there's a significant amount of evidence to show that not only do early warning signs predict, but also prevent and reduce severe maternal morbidity and mortality. Even though there are differences with the three scores, evidence still proves that any type of warning score that can initiate prompt intervention will improve outcomes for mothers, since we can identify these severe features for preeclampsia sooner and respond faster as a team. These three warning signs are valuable because in pregnancy and labor, small changes in vital signs and other clinical symptoms are easily overlooked. So to prevent serious outcomes for these mothers, warning scores make it easier to pay attention to these signs that put the patients at high risk. By identifying these risks sooner, we can succeed in keeping preeclampsia an avoidable condition by reducing potential escalation to eclampsia and reduce the risk for maternal adverse outcomes that could happen without the recognition of these features. Finally, I truly believe that as nurses, we bring awareness to the importance of blood pressure readings, intervening promptly by alerting the physicians for elevated values and ensuring accurate assessments for severe features, then the progression of this disease can be slowed or potentially stopped to prevent adverse outcomes for the mother and child during pregnancy, labor, birth, and the postpartum period. Thank you. Before I show my references, I would like to thank my honors advisor, Tammy Hall, who has supported me wholeheartedly through this whole process, and my nursing research instructor, Dr. Lori Hubbard, who helped me with every question possible about APA citations and a PICO question and anything else. And finally, Miss Jenny Clapp from Cone Health Women's Hospital, who talked to me for such a long time and provided me with the most invaluable resources I was able to use in this project. I would not have been able to do this without the three of them. So thank you.
Thank you very much, Grace, and for your informative presentation. Our final speaker will be Abigail Knight. Abigail is a senior pre-licensed nursing student at UNCG, completing full university honors in the Lloyd International Honors College. She is recipient of the Dean's Summer Research Assistantship through the Lloyd International College and the Charlotte and W. Dabney White Research Award through the Undergraduate Research Scholarship and Creativity Office. So now we'll hear from Abigail.
Hi, thank you all for being so patient. I appreciate my other presenters for being willing to step up when I was having some technical difficulties. And now that I'm here, I'm really excited to talk to you about my research project, End-of-Life Care, Assessing Knowledge and Perceptions of Nurses Working in a Neonatal Intensive Care Unit. So some team members, similar to Grace, I'm working with Jenny Clapp, and Dr. Carrie Hill is my faculty advisor, and we've also been collaborating with Jana Wright, who is a neonatal nurse practitioner in the Cone Health Women's and Children's Hospital in their level 3 NICU. So jumping right in, the burning question. So why do I want to pursue this research project? I'm currently doing a quantitative research project as part of my senior honors project, really focused on palliative and end-of-life care in the pediatric population. This topic is something that I feel like we don't really talk about much, and it's something that's not addressed much in nursing education and within the professional realm. And so with that being said, it's very easy for something like this to slip through the cracks and for the general public to not be very familiar with it, because it's hard for the public that we're caring for to be familiar with the topic that we're not addressing within healthcare itself. And so palliative care is something that's focused on comfort care. It's your quality of life. And palliative care is something that any baby or patient is eligible for at diagnosis of a chronic or life-limiting disease. And end-of-life care, of course, is an aspect of palliative care that really starts up at the diagnosis or the recognition that this isn't going any further, usually within 6 months or less to live. And so my idea was, what can I do as a future nurse to kind of understand what's the current state of nursing right now with the understanding of palliative and end-of-life care? And this is where this survey was born. jumping into trigger development, it becomes really important to know before we implement any kind of education or any kind of project that's going to hopefully address outcomes with palliative and end-of-life care specifically in the perinatal or pediatric period. We have to understand where we're at right now. And so that's why it's so important to have an assessment of baseline attitudes, perceptions, and knowledge of palliative and end-of-life care to understand the gaps between education and practice. So like I said, we can move forward and try to address some of those gaps. Similar to Grace, I had a personal experience with this that makes me very interested in end-of-life and palliative care. And it was growing up and watching my mom, who had a very traumatic loss in the NICU, kind of process that loss. And I believe that in her situation, the way that she describes it, she didn't have a lot of support, and the way that it was handled on the unit, it could have been handled better. And I don't think that's because the nurses or the doctors were trying to, make that a horrible experience for her. I have a feeling that that experience was likely just as traumatic for them. But I truly believe that they didn't know because they weren't trained and they weren't educated on how to handle a situation like this, simply because we don't talk about it. And so that's why, again, I think it's so important to start these conversations, because I recognize that that was just one experience, and it's very likely that either you or someone you know has had a very similar experience with loss somewhere within the pregnancy period with a child. And again, it becomes a very isolating and lonely time. And similarly, to kind of build on this and grow my experience, I've had the opportunity to shadow the bereavement program coordinator at Brenner Children's Hospital and really dive into this topic and really recognize that there are nurses practicing at bedside now who aren't comfortable with this topic, and that's something that we really need to address. So I had the primary research question: how do nurses working in a NICU describe their knowledge and experiences of caring for patients and families at end of life and or receiving palliative care? And kind of an offshoot of that, 3 specific aims that we had when we were developing our survey is to really get to the point of what are NICU nurses' understanding of palliative and end of life care, because it's very common that if you're having a conversation, you might bring up to a bedside nurse who's very experienced, is this baby a candidate for palliative care? And the immediate gut response is oftentimes, oh no, we're not there yet. We don't think that's going to happen. Of course, your understanding is this nurse thinks I'm implicating that I think this baby is going to die. Why are we trying to do anything else? When in fact, palliative care is a really important part of patient care that enhances quality of life and looks at all of these things, and doesn't necessarily mean that we think a baby is going to die. Something very interesting about palliative care that differs a little bit from what we know about adult palliative care is that in the pediatric realm, babies are actually allowed to continue getting life-saving or treatment while on palliative care. Because traditionally, when we think of palliative care, that's when we stop, kind of pursuing those things. So how did I get started developing my survey? We did a literature review. So the synthesis of my literature, I used PubMed and Sentinel databases for articles written within the last 5 years that really emphasize nursing perspective related to palliative and end-of-life care in pediatric critical care settings. And then I used the Johns Hopkins Research Evidence Appraisal Tool and non-research evidence appraisal tool to determine the quality and level of care, or level of evidence. So what does the body of evidence say? After doing all that, it became very evident that current nursing literature supports the supposition that registered nurses in maternal child specialties report even less positive attitudes towards end-of-life care than counterparts in other specialties. And that education and programs that have implemented educational opportunities experience all contribute to make more positive outcomes for registered nurses' attitudes towards end-of-life care. Because again, this is one of those topics where oftentimes you're going to learn at the bedside. We don't really get the chance to talk about it much in our education. And we also turn to literature to show us that registered nurses in the NICU specifically do demonstrate more positive attitudes of neonatal palliative care after receiving education. And the big benefit of this, well, that's wonderful for nurses, but what about our patients? Because that's who we're caring for at the end of the day. When your nurse and when your healthcare team are more prepared and open and able to talk about these topics, that improves the quality of patient care. Because at the end of the day, we can't save every baby. And as much as we wish we could, there are some things that we can't fix. And so when we reach that point and we recognize that we can't fix something, we need to be able to care for our patient and care for ourselves. And part of that is being willing, to talk about these things and to know what best practice is based on the evidence. And so based on the evidence that I found, came to the conclusion that there is need for a research study to understand better what current nurses are saying who work at bedside. This is how I feel about palliative and end-of-life care. This is what I know about palliative and end-of-life care. And this is what I've been taught so far. Again, so that we can, create new organizational opportunities. And so specifically, I was fortunate enough to be able to partner with Cone Health to develop this survey. And I plan to administer this survey to their nurses in their neonatal intensive care unit because this organization is in the process of developing a palliative care team. And so it's a really exciting opportunity to be able to come up with a survey and administer it to nurses at an organization that are at a really great time where they're going to be able to take some of this data and really understand where their nurses are at and be able to implement educational opportunities that will hopefully impact patient care and the quality or the happiness just of their nurses and confidence in providing care at this time. So my project plan, like I've been alluding to, I've developed an electronic research survey to gather, sorry, I went a little over, to gather quantitative nurse-reported data on knowledge, perceptions, and attitudes related to perinatal and pediatric palliative and end-of-life care. So who's eligible to survey? It will be administered to all nurses working in a bedside role within Cone Health Women's and Children's Center. It's a very brief survey, about 15 to 20 minutes on Qualtrics. I'm sure many of us have taken a Qualtrics survey and we're very familiar with how it works. So it won't be a big burden to nurses. It'll be really, streamlined and straightforward, and hopefully it'll give us data that we can use descriptive statistics to understand more. So a little bit more about the survey that we've developed. It's a 57 question Likert scale survey. And again, I'm pretty sure many of us have taken a survey like this. It's basically, do you strongly disagree, somewhat disagree, strongly agree, or somewhat agree with a statement, or you're unsure. And there's about 13 demographic questions, background questions. We've come up with about 10 of those. And those questions are really things along the lines of, what is your current understanding of palliative care? A select all would apply. What do I believe palliative care entails? And things like that. And that really goes to give us baseline data on what current knowledge related to palliative and end-of-life care is. And then the neonatal palliative care attitude scale is a 26 question validated scale by Dr. Victoria Kane, who is a very prominent researcher in the field of palliative and end-of-life care practicing in Australia. And over the summer, I had the opportunity to reach out with her and obtain permission to use her scale as part of this survey. And so that will be a 26 question piece of my 57 question scale survey. And then the last 9 questions are going to be very unit specific or organization specific to Cone Health to really hopefully understand more about where their nurses are at. And so questions like this are along the lines of, how willing do you think you would be to join the palliative care committee? Or how interested are you in something like this? Do you think education or training would benefit you? And to really get to the point of that. And so the goals, because we're currently in the process of still obtaining permission to implement this survey, this is what we anticipate happening. So my objectives, I intend to be able to describe the attitudes, perceptions, experience, and knowledge of palliative and end-of-life care in NICU nurses. The measurement that we've talked about earlier briefly is that 57 question Likert scale that we will be using descriptive statistics to understand. And I also didn't mention that as part of this survey development, I've worked with Dr. Hill, who's my faculty advisor, and Jana Wright, who I mentioned earlier. She's one of the nurse practitioners, to really come up with these questions. So after we developed our first draft of the survey, I administered it to a couple of the faculty members at UNCG who are familiar with research to get some of their feedback on what they thought we could change to make the survey better. And then finally, we went to Jana and I gave the survey to her and got her feedback on what she thinks would be important based on her experience with the organization, because she's very familiar with the unit that she works on. And that's where we're hoping to administer this survey. The results, we expect to be able to have a baseline understanding of this knowledge of palliative and end-of-life care. In conclusions, I anticipate finding that nurses are going to report feeling unprepared and uncertain when providing palliative and end-of-life care. Because again, based on current research, that's what we're finding. And based on my own personal anecdotal evidence, when I've had conversations with current nurses, that's what I find in our conversations, that a lot of the times, it's a very touchy subject that perhaps we don't want to talk about, or we just don't know how to talk about it. Nursing implications. It's really important that this new knowledge generated will be shared with key members of this developing palliative care team and used to support or inform their educational opportunities. And hopefully, as a new graduate nurse, it would be very exciting to see if some of the research that comes out of this and some of the conclusions and findings could be used by staff education at Cone Health to develop resources for their new graduate nurses. So those nurses that are going in brand new to the bedside, very excited with a lot to learn, but maybe who haven't thought about this aspect of caring for moms and babies, because it's not the most exciting thing to think about, even though it does happen. It happens quite frequently. Challenges on current project status. So just to give you an update, this project has been very ongoing. I've been working on it since March of last year with Dr. Hill to develop my survey and do everything. And so we're all very familiar with the COVID-19 pandemic, and that's really put a halt on a lot of things. So collaborating with an organization as external researcher is a barrier that I found, but I've been very fortunate in being able to work with Cone, and they've been very willing to have an external researcher. But it can be hard at some times to get into an organization when you don't necessarily know people directly. And so that can certainly add to project time. And that's something that I found, and I'm excited to know that going forward with any research opportunities, to plan accordingly. And then of course, COVID-19 impact on research as an organizational priority. Right now, nursing is very hard. For those of you who aren't directly in or related to nursing, I'm sure you've seen and heard things from family and friends who are really involved in nursing and with just healthcare in general. And so it's hard right now to be engaged with research because, again, with the pandemic happening, nurses are very burnt out. It's very hard, to add something else to their plate. And so I'm very, again, thankful for Cone that being willing to work with me during the COVID-19 pandemic. But of course, I have found that it's been harder, to get things going just because there's not time and there's not resources to necessarily dedicate for research like there would be, pre-pandemic times. And I alluded to it earlier, but currently with my project, I've got my literature review completed and again, developed my survey, and I've been collaborating with team members at Cone Health to kind of have a really great understanding of what this project is going to look like when it gets implemented. And I have also received IRB approval from UNCG, and I'm in the current process of getting Nursing Research Council approval from Cone Health. And I'm very hopeful that after that happens, I'll be able to implement my survey very quickly. But I do intend to finish this project, even if it's not before graduation. So I'm excited to see where this goes. And thank you all for listening. I believe that's the last slide. So if you have any questions, I'll be happy to answer them. Thank you.
Well, thank you, Abigail, and thank all of you for your presentation. So we now have about 20 minutes for questions. So let me see. Probably the best way if people would raise your hand and I can call on you, and we can then have one of our speakers address your question. I actually will go ahead and pose a question. I don't see any hands raised yet. So my first question is to Macie. Macie, I've been a nurse practitioner for 40 years, and nurse practitioners are nurses first. So I do believe that, we have a background in nutrition, but I applaud you saying that there's often not time. And so the question I do have for you is, do you think what could help the situation is realizing that, especially with Medicare, there's been a change that actually allows for nutritional counseling if people are actually referred to this service?
Yes, so is your question about insurance?
Yeah.
Okay, so I figured that a lot of people would have questions about insurance, so I looked it up quickly, and you are correct that from my understanding, based on state to state, Medicare now has to recognize nutrition counseling as like preventative care. And so I do agree with you that it's, insurance for everyone else, like who aren't under Medicare. It can be hard to see a nutritionist, and hopefully, as we continue to do more research, then insurance companies will begin to accept more nutrition counseling and people will see the benefit of preventative care. And I think that's one of the other issues is it's really hard to see the positive effects of preventative care if you don't have the disease in the first place. Does that answer your question?
Yes, and I do applaud that you brought up about, we know that food deserts do exist. And I think that when working with nutritionists, they can also be very helpful in letting someone know what are the resources within their community. But I do tend to agree with you that often it is a topic that's not brought up. And even as you're wondering, why didn't someone address this with me? Especially if somebody has, a family history of heart disease. So, so thanks for your response to that.
Yes.
So let me see, there might be a, so others with questions for our guest?
This is Lori Hubbard, and
Oh, thank you, Lori.
Hey, I'm just so incredibly proud of our presenters today and all of their hard work. I know I've specifically worked with Grace and Abigail, and you guys have been at this and just remained strong through COVID and have navigated and persevered. And if you are the future, we are in very good shape. I'm managing 2 different Zooms right now and have to hop back on a workshop, but I just wanted to say how proud I am of all of you ladies.
Well, thank you, Lori, and thank you for working with Grace and Abigail. So, Abigail, I do have a question for you. As you get ready to think about launching your study, I don't know if you know, there's been or noticed lately, there's really been a trend of using QR codes to disseminate Qualtrics survey. Are you thinking about doing that when you're promoting your advertising, to even include the ability to do it on one's phone?
That is a really great question. Thank you for bringing that up. And I didn't mention that, but that actually is part of my project plan. So it wasn't included in the presentation, but I do have a poster that I had to submit as part of the IRB process to get approval. And there is a QR code to my survey. And so hopefully that'll be in places that nurses can access it. So, staff bathroom, break room, places like that. But that's a really good question. And thank you for bringing that up, because I've definitely noticed that trend as well.
So I'm wondering, are you thinking of awarding any type of incentive or like a raffle or anything for people who would participate in this important study?
Mm-hmm. So for those who are willing or want to be involved or to, take part in a raffle, there will be 2 $25 Panera gift cards, because for those of us who are familiar with the Cone Health Hospital, there's a Panera on site. And so I'm hoping that makes nurses a little bit more interested or more willing to participate in this survey. Because again, I know it's a 15-20 minute survey. It's very brief, but nurses are already overworked and burnt out. And so I can understand where maybe 15 or 20 minutes, it's 15 or 20 minutes they don't have, to just sit in the break room and stare at the wall if that's what they need to do in silence. So I'm hoping that helps with survey participation a little bit.
And then I guess my next question would be, and again, I don't know that your population size, that is how many nurses who work within the Cone system, which I know has gotten much larger since I moved here over 30 years ago. But if you turn out things are successful, would you try to expand this to a greater population, North Carolina, or even the United States?
Absolutely. I'm very interested in seeing where this project goes. And so the current sample size at Cone, I believe we've been told, is around 90 nurses. And that would be in the perfect world if everyone was able to respond to the survey, which we're not anticipating. But after this project, I hope to go to graduate school one day. And so I'm really wanting to pursue this further. And I would love to look at, Cone Health is a level 3 NICU, go to level 4 NICU, go to NICUs in different regions, maybe regions that have historically less access to care, like our rural areas and areas with less access to technology and things, and just see just how we're, kind of spread out. And so that was a less eloquent way to say, yes, I would love to do that one day. And I'm excited to see where this takes me.
Well, and probably with the support of the faculty you've had, I wouldn't be surprised if they could even assist you in finding places where there would be grants to support this type of work. And then, as you were saying, looking at what are some educational interventions that you could provide, for this extremely difficult topic. And so it'll be interesting to follow your future. So I have a question for Grace. So Grace, I think it was very interesting hearing as a nursing student that you actually experienced this, and what I almost want to say the horror of, like, how did this happen, or why did this happen? That, and probably those words preeclampsia and eclampsia were something that you heard repeatedly and were almost as a student on the alert for, watching for, and you come in and you find out that something like this happened. And I definitely know of colleagues who experienced this, and it really, after that, I can honestly tell you, they chose to have one child. And it limited them probably in expanding of their family just because of the risk factor. So what would be kind of things you would even, would share with your fellow nursing students on implementing this or using one of those scales when you're currently in practice, whether it's I don't know, these are available as a pocket card or as an app that someone could use to do this kind of quick assessment?
I think I agree with all of what you said. Like, as a student, it was very jarring to be there that day. And like, I think we learned about it recently, and I can remember being there thinking, oh my God, why did no one see this? Like, how is this not so important? But also at the time, like, you don't really understand all the other things that nurses are doing all the time. And so for me, as a nursing student, just being told by my instructor, like, question those things. Like, when you're there and you see something, ask those questions. Ask a nurse, like, why didn't they give a medication? Or like, why did the medication they give not work? And why didn't they reassess that? And be willing to ask those questions. I think the idea of a pocket card is great. I also think, like, if we had something on Epic, like one of those like best practice advisories that pops up and it's like, your patient has this, are you looking at this, and this? And like, it won't let you click anywhere until you mess with that little box. So just have somehow, like, increasing awareness, whether it's a pocket card, something on Epic, just of what we should be assessing for beyond just these warning scores, because with greater knowledge about what we should be looking for to prevent the risk of preeclampsia, the greater ability of nurses to prevent this from progressing.
So we still have some time. Are there any questions in the audience? You could certainly unmute and ask one of our speakers.
Hey, this is Jenny Clapp, and I don't
Hey,
have.
Jenny.
Hey, Lori. I don't have any questions, but I did want to sort of. I wanted to ditto what Lori Hubbard was saying. Sorry, that's my grandbaby in the background.
Oh my.
That how much I enjoyed working with Grace and Abigail, and they did great work and had great presentations, and I hope that we'll be seeing them again soon. I think I heard you say Abigail, was it Abigail or Grace? No, Grace, I think, is going to be working at Wake Forest. And then I didn't know where the other one was going to work, but I hope to see them again soon. But just like Lori Hubbard said, I think our future's in good hands, being in the hands of these two ladies. And I didn't get to know the other student, obviously, because she did her work elsewhere, but I'm sure she's doing great work as well.
Thank you, Jenny. It was nice to hear you again.
And you too, Lori.
Yeah. So other questions, please feel free to ask our students. So Macie, I have another question for you. And I teach an RN to BSN class, and I have them do a 48-hour recall, and they're all nurses. And when they look at what they've eaten in 2 days, they're almost astonished. And to our two nursing students getting ready to graduate, many of my students work 12-hour shifts, and their time frame of when they even can eat and what they eat, and what they choose to eat. And, you know, how would you consider advising folks to find a way to incorporate good food within a crazy busy schedule, so that they're really including some of the foods on the diets you were referring to?
Yeah, that's one of the hardest things about being a nurse and being in the healthcare field, is oftentimes we're the ones who are falling behind and not able to take care of ourselves. And so I think that's a good question. And I think I'm not a nurse, and so I don't totally know like what day-to-day life looks like. But I guess some suggestions would be trying to, I don't know if you have access to a refrigerator or microwave. I don't know how all that works, but trying to go to the grocery store and buy snacks that are unrefrigerated, that, I don't know, maybe like popcorn, because that's whole grains, any kind of cracker that's whole grain, fruits that won't go bad, maybe like apples that aren't refrigerated, trying to find foods that you practically, well, even apples are hard to eat. They take forever. So it's not totally my field to have, like, I'm
Well,
not
yes,
a
I was
nursing
thinking
major.
about, I mean, your suggestions are really good, and I think a lot of it gets down to preparation. And Grace and Abigail, often when I'll tell the students, when I look at what they've eaten and I notice there's no calcium in it, because, you know, really the younger generations like are not drinking milk like they used to, or they just don't have time. I'm like, just put the yogurt and the fruit and the vegetables in a blender, and that will knock a lot off. And I mean, and sometimes you might have to drink it, you know, on the run, but I think we have to start these changes early. But I definitely agree with you that, you know, just writing a prescription is certainly not the answer. And a big topic we talk about now is social determinants of health. And there was a billboard, I'll never forget, in Louisville, Kentucky. And on the billboard, it said, food or cardiac medication. And so people are making choices. And what's interesting, Macie, is that while someone may give them a prescription for cardiac medication, it doesn't even necessarily mean they could afford to fill it. So ironically, is what you're suggesting is maybe some of them could come off of some of the medications if they were eating properly in the first place. And I mean, my sister, who's younger than I, had been treated for hypertension and has done a fantastic job. And they've actually lowered her medication and are considering her coming off of it. So we do see success stories of when people are really trying, or certainly people want to not go back and have, you know, bypass surgery and things like that. So I think we have to start young and being, you know, making suggestions. But let's be real, folks. Food has gotten to be extremely expensive, and I think it's made it even more difficult. So finding resources in the community will certainly be helpful.
Yes, and I think that's one of the benefits. I kind of touch on this in my speech, but a lot of people are, you know, the cultural aspects of food is really big. And that's where nutritionists are really important, because they can help people keep their culture, not lose their culture, not lose their friends, and still find a way to eat healthy and feel good about it and not feel excommunicated from their community. I mean, no one should feel that way because of food, but also people should feel good and be able to, like, if you're a nurse and you're feeling low energy and it's probably because of what you're eating, you know, maybe it's important to notice, like, hey, my patients are getting me at my best. So maybe if I take an extra couple minutes to eat, I'm going to feel better. I'm going to be able to treat my patients better. And that's something that the hospital needs to recognize too, in order to help encourage nurses to have more time. And I know that COVID-19, the staffing shortage is crazy and it's hard. No one was prepared for nutrition in COVID healthcare.
No, definitely great point. Grace, just a question I wonder is that those patients who end up having preeclampsia, I wonder if in any of your reading, did they go on to still experience hypertension later or once, or any other comorbidities?
So yes, when
Reason to stop
when a
this.
mother has preeclampsia, they then are at risk to have sustained high blood pressure postpartum. So that's another reason that when we catch it earlier and we treat it, it can be slightly elevated, stay slightly elevated throughout pregnancy, but not progress to have any of those other severe features. But then when it progresses more, you're also put at risk to, there are times where preeclampsia can continue on into the postpartum period. Like they give birth and sometimes these seizures and all these other features don't stop. So it can become very risky and have lots of long-term comorbidities. Yes.
I think, Grace, you brought up an excellent point that it doesn't necessarily need to end when the baby's born. Even if the baby's born healthy, there can be the longer lasting side effects that can go even months and so afterwards. So again, so important and something that seems so simple, but applaud you for recognizing that as a nursing student. So, well, I want to certainly thank the three of you. This was extremely informative and I've enjoyed being your moderator, and I wish you certainly success in your future and hope I run into you. Now, I won't be having any more babies, that's for sure. Someone who had a baby when she was practically 40. I don't think there's another one in my future, but you never know. Maybe I'll be a grandmother way down the road. So thank you all for attending this honor symposium. And I hope some of you will consider attending some of the afternoon sessions. So anyone has anything else? Otherwise, we will close this session for now. And again, thanks to all of you for entering and participating.
Thank you.
Thank you.